Good afternoon, and thank you for joining the RLS Foundation's webinar titled RLS and Comorbidities. My name is Adriana Colucci, and I'm the Administrative Assistant here at the RLS Foundation. The RLS Foundation has been using a new webinar platform, Zoom Webinars, for this and all future webinar events. To ensure seamless webinar access, confirm that your Zoom app is up to date with the current software. If you need help accessing the live webinar on your computer, please call the phone number listed on your registration confirmation email for assistance. If you have any other questions, please email clara@rls.org. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. The presenter will answer as many questions as time allows following the presentation. After the webinar, the recording will be made available in the member portal section of our website on the next business day. If you are not a Foundation member, and if you would like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting that they may have RLS should consult a qualified healthcare provider. The information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a healthcare provider. Our speaker today is Dr. Kunal Agarwal. Dr. Agarwal is board certified in family, obesity, and sleep medicine. He received his bachelor's degree in neuroscience with honors from Johns Hopkins University and his medical degree from Ross University School of Medicine. He completed his residency in family medicine at Western Michigan University School of Medicine and a fellowship in sleep medicine at Henry Ford Hospital. He is a fellow of the American Academy of Family Physicians and the American Academy of Sleep Medicine, and is also a member of the Obesity Medical Association. Dr. Agarwal has been named a top doctor by Delaware Today magazine for 2017, 2018, where he was featured on the cover, 2019, 2020, and 2021. He has presented international lectures and media interviews, published peer-reviewed articles, and enjoys educating colleagues and the public. In addition to treating both adult and pediatric sleep medicine patients, Dr. Agarwal is experienced in Inspire therapy for obstructive sleep apnea and Remedy therapy for central sleep apnea. Thank you, Dr. Agarwal, for sharing your time and your expertise with us today. I now invite you to begin your presentation.
Thank you so much for that introduction. I'm really excited to present this topic tonight, and hopefully we all learn something. I'll just preface by saying I am not an academic, but I will try my best. But tonight we're going to be talking about restless leg syndrome, or RLS, and comorbidities. I will also say that there's not too much research on this topic, so I tried the best to see what I could find out and educate everyone. So let's get started. So family history and genetics. So there's a family history of RLS in 40 to 60% of cases. So typically if you have a family member with it, you're more likely to have RLS symptoms. Twin studies show a high concordance rate. So a lot of twins also have RLS symptoms as well. It typically is an autosomal dominant pattern, meaning that pretty much every generation gets RLS symptoms. So it doesn't really skip a generation, but typically every generation. There was a alpha-synuclein promoter REP1 allele 2, which is a risk factor for Parkinson's disease. It seems to protect against RLS, but it's also been linked to RLS as well. Protect against RLS. There's also been associated genes which are listed here that they've been found to have been linked to RLS as well. Low iron stores. So reduced iron is really a consistent finding in patients with RLS. So typically when I see a patient with RLS symptoms, I typically order an iron panel, which includes iron, TIBC, ferritin, which is a iron storage level, to look for these levels. A low serum ferritin level, typically below 45 or 50, correlates really strongly with RLS. And typically, if it's below, I use a cutoff of 70, then I would treat those patients with oral iron supplement. And typically, I do like 325 milligrams, 1 or 2 tablets a day. And I encourage patients to take it with vitamin C to help with absorption. And then I typically check labs a couple months later to see if they've improved. And if they haven't, then I send them to hematology to get IV transfusions with iron, because sometimes they just need a transfusion. And patients describe it like feels like spinach. And most of these patients are actually not anemic. So sometimes patients, tell us that my iron levels were checked and they were normal, but it actually, just because your hemoglobin is, normal doesn't mean you're necessarily anemic. So hemoglobin and iron are two different things. Also of note, a normal range of ferritin on the lab report does not really exclude iron deficiency. So you kind of have to look at the whole picture. But, supplementing low iron stores is a really important thing to do for RLS patients, because generally if you supplement and their levels go up, their symptoms significantly improve. Sometimes it goes completely away. So another comorbidity is uremia. So what is uremia? It's a condition involving really abnormally high levels of waste products in the blood when the kidneys are not filtering properly, typically seen in patients with kidney disease or kidney failure. Uremia secondary to renal failure is really strongly associated with symptoms of RLS. And in these patients, the symptoms are typically very severe. 20 to 73% patients have RLS in renal dialysis patients. So it's pretty common in such patients. And risk factors for these patients include anemia, iron deficiency, diabetes mellitus, high parathyroid hormone, high homocysteine, being a female, and younger age. These patients also have high periodic limb movements. So what this means is when you have the sleep study for patients, they are actually kicking their legs when they are actively sleeping. And both RLS and PLMs have been associated with increased mortality or death in the dialysis population. So it's something to take really seriously. Of note, if you have a kidney transplant, this usually leads to improvement in RLS symptoms pretty quickly, within a few days or weeks. So you want to be cognizant of patients with uremia or dialysis or kidney disease, because a lot of these patients have RLS and they're already fatigued as it is, just because they have to get dialysis a couple of times a week. So you want to really look at their lab values and do what you can to help make these patients feel better. Neuropathy. So as we know, neuropathy is described as burning, shooting electrical pins and needles in the arms, legs, feet, and hand. Of note, like sometimes this can overlap with restless leg symptoms. So sometimes it can be a little bit confusing about which is which. But something to consider is symptoms occur during the day and the night when you have neuropathy, but RLS mainly occurs at night. Also, movement makes neuropathy worse, whereas for RLS, it actually makes it better. So that's something as you can differentiate between neuropathy and RLS. Neuropathy has been related to diabetes, which is what we commonly see, diabetic neuropathy. Alcohol intake, amyloid, polio, and radiculopathy, which is pain in your back, have been observed with increased frequency in patients presenting with RLS. I would say 5 to 10% of patients usually have neuropathy and RLS, but this may be overestimated just due to the overlap of symptoms, which I described earlier. So it may be hard to actually judge which is RLS, which is neuropathy, or which is both. He also mentioned that axonal neuropathies have a stronger association with RLS than demyelinating neuropathies. So to differentiate, demyelinating neuropathies typically see a reduction in conduction velocity, whereas axonal shows a reduction in amplitude. So this is a different type of neuropathy. Another comorbidity is spinal cord disease. So if you have traumatic spinal cord lesions from a car accident or some major accident, spinal cord tumors, which are impinging on the spinal cord, demyelinating or post-infectious lesions, and syringomyela, which is like a fluid-filled cyst, which forms within the spinal cord, can all precipitate RLS and PLMs. Of note, spinal cord blocks, which are used for anesthesia, can also frequently cause or exacerbate RLS symptoms. There is one prospective study that showed about 161 subjects without a history of RLS, 9% of subjects developed RLS symptoms immediately following spinal anesthesia. So you want to make sure the anesthesiologist is good. But yeah, so if they typically have like spinal cord injuries or tumors or whatnot, symptoms can definitely get worse. So obviously you want to treat the injury, so hopefully you don't get these RLS symptoms or get worsening of symptoms. Pregnancy is a big one. So there's a 2 to 3-fold higher prevalence than the general population for these symptoms. 1 out of 5 individuals have RLS, which is about 20%. And if you have pre-existing RLS, this accounts for about 4 to 33% of cases. Typically, symptoms get really worse over the course of pregnancy. So it's typically worse in the 7th and or 8th months. But typically they spontaneously resolve shortly after delivery. RLS is the 3rd most common reason for insomnia during pregnancy. So that's something to consider because you want to make the pregnant lady's life much easier. So you want to treat the RLS, but so it also helps with their insomnia. There's more frequent maternal complications reported, such as gestational hypertension, preeclampsia, gestational diabetes, and peripartum depression. And so we want to avoid all these to make sure everything's healthy for the baby and the mother. If you need to treat for RLS in pregnant patients, you want to avoid the typical medications are typically prescribed for the general population just because they can be detrimental to the mother and the child. So if you need to give something, they recommend low-dose clonazepam, which is Klonopin, or low-dose carbidopa levodopa. But they try to recommend to stay away from the alpha-2 ligands, which include gabapentin and Horizons, as well as ropinirole and pramipexole and whatnot, just because of those harmful effects on the baby and potentially the mother, as well as lactation. So. Multiple sclerosis is another one. So this is when the immune system really eats away at the protective covering of the nerves, and they have a lot of symptoms. The prevalence for RLS estimates ranges from 10 to 60%. And risk factors for RLS among individuals with MS include increased disease severity and the chronic progressive form of the disease, so if you're on the worst end of things, and spinal cord lesions. So typically they'll also have symptoms of tremors and vision problems, but RLS is pretty high prevalence, so you have to take that strongly into consideration as well. Parkinson's disease. So as we know, this is a disorder of the central nervous system that really affects movement, including tremors, as well as stiffness and loss of balance and memory. And nerve cell damage in the brain can cause dopamine levels to drop, leading to the symptoms of Parkinson's. The prevalence of RLS in patients with Parkinson's is about 15 to 20% in populations with European ancestry. Interestingly, if you're Asian, it has been shown to have less prevalence. And RLS symptoms are short-lasting and not severe in these patients and can be confused sometimes with Parkinson's symptoms such as wearing off dystonia, which is involuntary muscle contractions, akathisia, which is an inability to stay still, or an internal tremor. There is no evidence that RLS is a precursor to Parkinson's. So I think that's kind of interesting because there's another sleep disorder called REM behavioral disorder, which is when you're in REM sleep, patients can act out and move their arms everywhere and hit their spouse and get violent. And that has been shown to be a precursor for Parkinson's, but RLS is not. Cardiovascular disease. So RLS has been associated with cardiovascular disease. There was a study showing that about 2,800 men with the average age of 76 enrolled in centers showed that the syndrome was specifically associated with the incidence of myocardial infarction, which is a heart attack. So you want to take RLS pretty seriously because you don't want to get a heart attack. It's also been associated with congestive heart failure, so your heart's not pumping well. and has been shown to increase cardiovascular disease mortality. The frequency of RLS increases to a greater extent when certain conditions are met, and these include cardiovascular disease, diabetes, hypertension, and/or depression. In terms of how this really works, the postulated mechanisms include increased sympathetic activity, so like the fight or stress response, oxidative stress in the body, metabolic factors, and significant inflammation. So you definitely want to treat cardiovascular symptoms and RLS symptoms together so you get a healthier life. Diabetes. So diabetes mellitus is, type 2 is when the body doesn't either produce enough insulin or it resists insulin. And this is really a chronic condition that can affect the way the body processes blood sugar or glucose. There was a study showing that between 25% of people with diabetes showed signs of RLS, and people with diabetes had an increased risk of developing RLS compared to people without diabetes. And also, like I mentioned earlier, diabetes patients can also have sometimes associated neuropathy, which can also be confused with RLS symptoms. So you want to address everything together. Major depression. So depression and RLS are frequently, coexisting together. And depressive mood symptoms have an effect on RLS and related features, such as clinical features, of course, the treatment and the outcome. There are some earlier studies addressing the prevalence and showing that there's a prevalence between 0.9 to 8.3% in the Asian community and 17.7% in the American community. One study examined the frequency of RLS symptoms in depressed subjects, and so there was a prevalence of 27%. So they're pretty high numbers. RLS patients often suffer from chronic insomnia, and its clinical presentation, frequently masquerades or induces depression. So that kind of all go together. Similarly, I think also if you have generalized anxiety, that can also worsen RLS symptoms as well. Obstructive sleep apnea. So we see a lot of this in the clinic. So this is when there's an intermittent airflow blockage during sleep with symptoms of snoring and daytime sleepiness. Obstructive sleep apnea, or OSA, and RLS are very two common sleep disorders that frequently coexist within the same patient. And generally in my practice, or when I see patients, I diagnose the sleep apnea and I treat that, because generally if you treat the sleep apnea, the RLS symptoms get better. One small prospective study found that significant RLS was found in 8.3% of OSA patients, in contrast to about 2.5% in the control group. Interestingly, they don't really share a common pathophysiological mechanism of how the things work, but the presence of one with the other increases the severity of both others. So if you have, really severe OSA, and then you might have really severe RLS, and vice versa. And obviously, the treatment for RLS in the context of sleep apnea should be started as well in conjunction. And so there's some other limited data and some other associations as well, including essential tremors, as well as genetic ataxia, so people who have really abnormal gaits and it's genetically inherited. There's also a disease called Fragile X, which is when patients, particularly younger boys, have large ears, longer face, prominent jaw and forehead, and flat feet. And these kids also have delays in talking, anxiety, and hyperactive behavior. Fibromyalgia has also been linked to RLS symptoms, as well as other rheumatological conditions, including rheumatoid arthritis and Sjogren's, which is when you have dry mouth and dry eyes and whatnot, and migraines. I will also mention a lot of autoimmune disorders going together from rheumatoid arthritis and Sjogren's, including like Crohn's disease, also have been linked to RLS as well. And that's it.
All right. Thank you so much, Dr. Agarwal, for giving us a thorough overview of some of the comorbid conditions that can occur with RLS. So we had a lot of questions submitted in the registration process. So we're going to go ahead and jump into some of those and try to answer as many as possible for you all. So the first one we have is, does neuropathy have any connection with RLS, and are there any similarities between the two?
Yeah, so as I described earlier, there are some similarities, and I described neuropathy It's a more burning, shooting electrical pins and needle type of sensation, whereas restless legs is the urgency to move your legs, and you can't sit still. But the symptoms typically occur during the day and the night for neuropathy, whereas RLS is mostly at night. And like I said earlier, movement makes neuropathy worse, whereas it makes RLS improve. So I think that's some points to differentiate between the two.
Is there a relationship between RLS and a heart murmur?
So I'm unsure specifically for heart murmur, but definitely it's been linked to cardiovascular disease, which we talked about earlier. So obviously, if you have a heart murmur, you want to get worked up and get an echocardiogram and ultrasound of your heart to make sure nothing's going on significantly. But if you do end up having cardiovascular disease, that has been linked to RLS.
Is there a higher incidence of generalized anxiety disorder in people with RLS?
Yes, so I saw some research showing on that as well. Typically, if you had more anxiety, that can cause some more stress and overstimulation, and vice versa. Uncontrolled RLS can exacerbate anxiety. So you want to address both and treat both together.
And you addressed this a little bit in your presentation, but has RLS been linked to MS or diabetic neuropathy?
Yes, to both. So we had slides on both. It's interesting, yeah. So you want to, if they have both, you want to treat RLS symptoms and MS and diabetic neuropathy as well.
And how about an essential tremor? Is there any relationship between an essential tremor and RLS?
Yeah, so there's limited data showing that they have been linked, and you want to treat both essential tremor, whether it be with some medications can help with it, like primidone or beta blockers, but it has been shown to be linked to RLS, yes.
If one reduces a comorbidity associated with their RLS, does that help mitigate the symptoms of the RLS itself?
Yes. So a lot of the stuff you mentioned, like they go hand in hand, right? So you want to treat everything you can. So typically, if you treat their diabetes, if you treat their cardiovascular disease or depression or their anxiety, hopefully the RLS will also get better. But at the same time, you still want to address the RLS symptoms as well. So whether it be with iron supplements or medications, you want to address both.
Is type 2 diabetes considered to be a comorbidity?
Yes, so there's some data showing that patients who have diabetes and especially more severe diabetes can also have RLS, which is different than diabetic neuropathy. So you want to improve and optimize the sugar control, so you can also hopefully prevent from the RLS to get worse.
Is fibromyalgia considered a precursor to RLS, or is it considered a comorbidity?
So yeah, fibromyalgia has been mentioned. There's a few case reports about that as well. In terms of if it's a precursor or comorbidity, I mean, it's kind of like the chicken or the egg, but I think they both go hand in hand together. Fibromyalgia in itself is really hard to treat, but if you're able to optimize the treatment for that, then hopefully the RLS will get better and vice versa.
Okay. What is the most common condition or comorbidity associated with RLS?
So I don't know what the most common is, but I would probably say, iron deficiency, just because it's so prevalent in patients who have significant RLS. So definitely, if you have patients to have symptoms with that, I would definitely do the workup to make sure they're not iron deficient, and if they are, to supplement that.
Is there a connection between RLS and ADHD?
Yes, I think there are very few case reports, but they do show that children with ADHD are more likely to have RLS symptoms. So you want to optimize, whether it be behaviorally or medication-wise, their ADHD symptoms. So hopefully the RLS symptoms also improve.
Are there any other conditions that have the same symptoms as RLS, or can they mimic the symptoms of RLS?
So some other diagnoses that may mimic RLS include nocturnal leg cramps, claudication, so there's not proper blood flow, neuropathy, which we described earlier, and akathisia, which is the inability to stay still, which you see in Parkinson's patients. So you kind of have to differentiate, which is which. Sometimes it can be a little bit confusing because sometimes they kind of overlap. But that's where a good history and good exam of the patient and getting proper workup, including blood work. So in addition to iron, you may want to check B12, their folate, magnesium levels. And if you think it's a vascular issue with blood flow, you may want to get an ultrasound to make sure it's properly artery and venous flow. And then also, if they have like akathisia, they can't sit still, then you may want to ask questions about memory and or like tremors to see if they possibly have Parkinson's as well.
Can herniated cervical discs increase the incidence of RLS?
Yes, so I think they have found case reports showing that as well. There is a theory that if you have damage to the sensory spinal pathway, it really affects the brain signals, probably affecting dopamine as well, which is a big marker and player in restless legs. So that has been caused to be linked to restless leg symptoms as well.
And how about a connection between vestibular migraines and RLS? Is there one?
Yeah, so I think if you have migraines that has been linked to RLS, there have been case reports about that as well. Yes.
All right, moving on. Can progressive Raynaud's or neuropathy contribute to more frequent or more severe episodes of RLS?
So this one I'm not too sure about, but I did find one case report showing that a family had a history of RLS as well as Raynaud's, and things got worse, but they're really unsure of the cause. But if you're in the autoimmune category, like anything is game, so like it can be linked to RLS, but I haven't seen too much literature about the subject.
Is there any connection between RLS and small fiber neuropathy? And I may say this incorrectly, but Sjogren's syndrome?
Sjogren's, yeah. So so Sjogren's and neuropathy and fibromyalgia and rheumatoid arthritis and Crohn's, a lot of them are autoimmune diseases. So a lot of them have links to RLS.
Is there a connection between RLS and plantar fasciitis?
Yeah, so this one I had to look up because I haven't heard this one before, but I did find that, RLS is caused by, lots of movements and there's stress and strain to the myofascial trigger points and in the skeletal muscles of the feet and legs. So some experts believe that the gait or the way patients walk changes, and that often occurs alongside when they have plantar fasciitis because they can't compensate or start to compensate for the damaged fascia, which can trigger restless leg syndrome. So this is where you see the podiatrist and, wear, good supports for your feet and good shoes. And sometimes you need medications or injections to help with the plantar fasciitis, but I guess there is a link with restless legs, which I didn't know about. So it's pretty cool.
Are there any known comorbidities that are related to back problems, such as herniated discs?
Yeah, so as we mentioned earlier, like if you have some spinal cord injuries or spinal cord tumors or herniated cervical disc or thoracic or lumbar, it affects brain signaling and the sensory pathways, and that can participate RLS symptoms.
Is rheumatoid arthritis one of the comorbidities, or is it just arthritis in general?
I would say more rheumatoid arthritis just because it's autoimmune, whereas osteoarthritis is more like wear and tear. So because of the oxidative stress and inflammation with autoimmune diseases, then I think those are more common in those patients.
Right, and then the last one here, does having severe RLS/PLMD make it more likely for you to have a TIA? And can you clarify what TIA is?
So TIA is a transient ischemic attack or a mini stroke. So I looked this up as well. So I found some articles showing that people with RLS are twice as likely to have a stroke or heart disease compared to people without RLS. And the risk is greatest in those with the most frequent and severe symptoms. Conversely, there's a study showing that among 137 patients, 17 patients, which is 12.4%, were diagnosed with RLS after a stroke. So it can go either way, but you want to minimize all these risk factors for a stroke. So that includes your blood pressure being controlled, no smoking, cholesterol is controlled to prevent a stroke or mini stroke, and potentially exacerbate RLS symptoms as well.
All right, so we had so many questions that were submitted, but we certainly don't want to overwhelm you. RLS is connected to many parts of the body. So I want to thank you to all of our registrants today for tuning in to today's webinar. And thank you, Dr. Agarwal, for your time. For those of you, you can register at our next webinar at rls.org and visit the Education and Events page under the Get Involved tab. As a reminder, we are also hosting another RLS patient symposium in October at the beautiful Maritime Conference Center in Baltimore, Maryland, and it will take place in person. To learn more about this exciting event, you can also visit rls.org to register and learn more today. Thank you so much again. We hope you enjoy the rest of your evening.
Thank you.
Thank you.